days, our work has expanded to include economic justice, environmental justice, women's rights, health and welfare, immigration justice, gun violence prevention, which are all intersectionally related to race. In these 85 years, the Council has acted courageously in the face of hostility and spoken prophetically in the face of injustice. Friends, we seek to do nothing less today as we partner with the North Carolina Department of Health and Human Services to address specifically the crucial role our faith communities are playing in the face of this COVID-19 pandemic. We know that faith communities are both meeting the critical needs of the people in their communities while simultaneously serving as a role model for what it means to love our neighbors by keeping our distance from them. All of you out there are doing this every day, and it is our aim today to acknowledge your faithful witness and to connect you with the people who can help resource your efforts. But before we dive in to this very practical information and useful information, we are pausing as people of faith to cry out our lament before God. Let us cry aloud as we lament the loss of life exacerbated by this pandemic. We lament the economic struggles created by this pandemic. We lament the weariness of our essential workers necessitated by this pandemic. We lament the loneliness experienced by so many because of this pandemic. But most importantly, friends, we acknowledge the hope of God's promises for us that our laments are heard. Amen. And now let me introduce to you someone who is likely well known by many on this call, the Council's Director for Partners in Health and Wholeness, Chris Cornell. Thank you, Chris.
Thank you, Jennifer. Welcome, everyone. For those of you who may or are not familiar with Partners in Health and Wholeness, we have been operating for about 10 years, working individually with faith communities all across North Carolina in your health ministries. As you, we have never seen a year like 2020 with COVID-19, but what we have seen and what we've been a part of is just an amazing response from you and other faith communities across the state in meeting immediate needs and looking at the long-term needs that we will still be looking at for the foreseeable future. We are thrilled to partner with agencies like DHHS and to have them here today. If you have any questions or you want more information about Partners in Health and Wholeness or the North Carolina Council of Churches, we will be putting our information in the chat box and happy to talk to you after this event or at any time convenient. But I want to introduce the speakers who are going to join us today. Dr. Betsey Tilson with the North Carolina Department of Health and Human Services. She is the Chief Medical Office and State Health Director. And Carla West, the Senior Director of Economic Security. We also have joining us from White Memorial Presbyterian Church, the Pastor Christopher Edmondson, and from Robeson County NAACP, Dr. Robin Peace, and the Reverend Tyrone Watson. We also have a few folks in the room that are going to be helping us monitor the chat box. This is one of the largest events we have done this year. So any questions you have, any comments you would like to share, please put in the chat box and we will either answer them in real time or we'll have answer them in the Q&A session a little bit later. You're going to see three names, Madhu and Charlene and Walker, and you will see them answer questions with resources or quick answers if it's something that we don't address in the Q&A. So please watch out for those three names if you do have any questions. So at this time, I'm going to turn it over to our partners with the Department of Health and Human Services, and Lindsay is going to share her screen, I believe, with some slides. Thank you so much for joining us.
Wonderful. So I will jump in. And I think we can then just move right on down to slide number 6, as we did a lot of that introduction prior to the slides. Wonderful. So once again, my name is Elizabeth Tilson. I serve as your State Health Director and the Chief Medical Officer for Department of Health and Human Services. And we are so excited to join with you today. This is such an important conversation, and you all are such important partners and stakeholders and trusted voices, true leaders and trusted voices in your communities. And so we are so grateful to have this opportunity to share information with you that maybe you know and we can reinforce, maybe learn some new things, offer some suggestions of things you may be able to do, but also as an opportunity to learn from you, learn from your expertise, learn from your lessons learned, learn from your leadership, and to teach us as well as what might be effective and what maybe some of the things we're doing that aren't effective. I think we all join in the goal of wanting to protect our people, preserve health, ensure that our state and our people are as healthy as possible in mind, body, and soul. So we really appreciate this, and we hope that this will be one of many ongoing conversations, and that we can serve as a resource to you for whatever questions you may have today, and then also in the future. So with that, go ahead. Why don't you move to slide 8? And I'm just going to just ground us just a little bit in the science behind COVID, so that we all are just starting with some common basic knowledge. And then I'll turn it over to my colleague to think through what are the resources that we have for you and tools to help you operationalize some of these science-based recommendations. So the first, just again, level-setting topic is just what do we know about COVID-19? What do we know? How is it spread? And what are we still learning? And the one thing that I really want to emphasize on this slide is what are we still learning? We continue to learn every day about this virus. My daughter reminded me that yesterday was the anniversary of the first person who had been diagnosed with COVID-19. So this virus did not exist a year ago, and so we are continuing to learn more and more and more about this virus. That's one thing as we're continuing to learn, and so sometimes you'll see some of our guidance and our recommendation changes as we learn more, and that's a good thing. That's us continuing trying to improve and learn. But if we move to slide 9, the next slide, what I'll tell you is just re-emphasizing some of the things that we do think that we know right now. One is, what's the main way that this virus is spread person to person? We still think that the main way it's spread is what we call respiratory droplets. So those small little droplets of saliva or moisture that comes out of your nose or your mouth when you're talking, when you're breathing. And the other thing that we are learning is that when you're doing something that we call has increased respiratory effort, any reason that those respiratory droplets or those vocal patterns are increased, that can then increase the spread of those respiratory droplets. So thinking about if you're talking really loudly, or you're yelling, or cheering, or singing, and we're going to get back to that because we had lots of questions, and I know this is a really, really hard and really important one for this audience. So those some typical everyday things, and then also if you have symptoms, if you are coughing, if you're sneezing, if you can think about the force of that exertion when you're coughing and sneezing, that is increases the risk of transmission. What we're also learning is there are other modes of transmission. We've talked a lot about cleaning surfaces because we do know that some viruses can be spread by if someone is coughing or sneezing or talking, those respiratory droplets land on a surface. You touch that surface. Now the virus is on your hands, and then you touch your mouth or your nose or your eyes. That's another way of transmission. What we're learning is that's probably less so. It is more that direct person-to-person respiratory droplet, but there is an element of that environmental contamination. And the other thing we're learning more about is airborne particles. So those airborne elements that can maybe suspend in the air a little bit longer and can extend and travel farther than the typical 6 feet person to person. We're learning more about that. We do know there can be airborne transmission. Some of the things we're learning is that that's more likely if you're in a small indoor space we have lots of people and poor circulation. There has been some case studies of clusters and outbreaks in those settings, which is one of the reasons that we talk a lot about making sure you can do things outside or opening the windows or really ensuring that you're having increased ventilation. And then the last thing that we're learning is different than other viruses, especially different than other respiratory viruses. What we are learning is that more and more, maybe even up to 75% of people with the infection may not have symptoms or may have symptoms so mild they don't even know about it. That is a huge amount of the population that may have infection. And then we're learning is that you can still, even if you don't have symptoms, you can still spread the infection to other people. That's really important and something that we're learning that is more of for this virus than other viruses, which is behind that recommendation of wearing a face covering all the time, not just when you're sick, but all the time. Okay, the next slide, please. I wanted to touch on this just a little bit, and we did get these questions in the chat box ahead of time, specifically around singing. Of course, that's a really important piece. Singing and chanting, obviously a really important piece of our religious gatherings. Unfortunately, I wish I could say it doesn't increase your risk, but unfortunately what we are finding is that singing can increase the risk of spread. Again, it's just that respiratory effort, that pushing out of those respiratory droplets. And so here is just one study that showed a very, very high attack rate of people getting sick after a choir practice. That you can see about 87% of people in the choir in practice ended up becoming infected from that singing. So we can talk about ways to maybe mitigate that risk, but I do want to emphasize that singing does seem to be a pretty high risk activity. Okay, next slide, please. And then the other piece just to point out is that, and I hope you all are aware of our dashboard. We're trying to be very transparent in a lot of our data. We have a big public dashboard, and one of the things we do post are clusters, so outbreaks are clusters. And we have seen, especially in October, we did see a fair amount of clusters that were originating in our religious gatherings. Thankfully, that has come down, yay, and thank you all so much for the effort that you've put into hopefully help us change those trends. But we do see religious gatherings as an area of relatively high clusters and outbreaks. Okay, next slide, please. Just a little bit of what are we learning about the short-term, long-term effects if you are getting infected? What does that mean? I mean, we do know that there can be short-term illnesses, but we're learning more and more that there can be long-term symptoms and effects as well. So on the next slide, we'll just talk a little bit about those people who are at increased risk, especially for those short-term illnesses. So people that can get into big trouble with respiratory illness, not being able to breathe, needing to be in an ICU, needing to be on a ventilator, really, really struggling with severe respiratory distress and illness. And what we are finding is that your risk of severe illness is increased if you are older, over 65. And you can see on the left, this is the risk of being so sick you need to be hospitalized. And then on the right, this is the risk of dying from the disease. And you can see that it does increase the older you get. Now, not completely, and we are seeing, unfortunately, more and more younger people, especially amongst our African-American population, having more severe illness with the infection. And the other thing that we are learning more and more is that people of any age with certain underlying medical conditions can also put increased risk of severe complications. So example, cancer, heart conditions, diabetes, obesity, and then there's the new data that we've been suspicious of, but some confirmatory articles that came out just a week or two ago is pregnant women. We know that other respiratory viruses can put pregnant women at higher risk as well. And on that bottom is a link to the CDC website that lists all of those medical conditions that either know we put at increased risk or might put you at increased risk. So when you think through your congregation, especially if you have an older congregation maybe, or congregation with underlying medical conditions, understanding that those people are at higher risk for severe illness if they were to get the infection. So that's kind of short-term risk. On the next slide, there you go. What we're also learning is that although this is it's spread in a respiratory way and acutely, it's a respiratory symptom, what we're finding is that it doesn't just stay in your lungs. And what we're finding is that it really can affect your whole body. It can have inflammation in your blood vessels that can affect many, many different systems and organs. So it can affect your heart, your brain, your kidneys, and that even the folks with mild cases still may have this ongoing chronic disease, probably from that inflammation, and can really affect their quality of life for weeks, maybe even months after. And then you can see on the right-hand side some of these prolonged symptoms: fatigue, loss of memory, concentration. Again, we think that affects the brain cells. This loss of smell or taste, lack of concentration, shortness of breath, and what we're learning more and more is the term is long haulers, those folks who still have these persistent symptoms. And for adults, that may be almost about 2/3 of adults may have prolonged symptoms. And even young, healthy people, 20% of young, healthy people may have these longer-term symptoms. So that's something we're learning more and more about. The next slide, please. So just thinking a little bit more about our religious organizations or settings, and so what might make our religious organizations particularly susceptible to the spread of COVID-19. And so on the next slide, we'll get to that. So again, getting back to the main way that this virus is spread is people to people, respiratory droplets within 6 feet. And so anytime you get people together, there's a risk of spread. The more people that get together, the more the chance of the risk of spread, especially remember to think that maybe 75% of the people may have the infection without symptoms. So the more people get together, the higher the likelihood somebody may have the infection and not even know it. And so anytime a group convenes for whatever purpose, be it worship service or Sunday school, social gatherings, community service, for whatever reason, there's a risk of gathering. And of course, we know that is the core of a lot of our religious faith is that gathering, that coming together. And so that just by the very nature of our worship services, that increases risk. And then just thinking through what are those specific activities or settings that might increase the risk in these settings. We talked about singing, unfortunately being a relatively high-risk activity. Also sharing worship materials, again, maybe less that idea that environmental contamination, but still a risk. If people are sitting close together within 6 feet and for extended period of time, so within 6 feet for more than 15 minutes, we know that can increase that risk of spread. And then, as I alluded to, indoor gatherings also increase that risk of spread because of that poorer ventilation. So those are some of the reasons why we think there may be a little bit more spread in religious settings. So what can we do about it? On the next slide, please. What are some just very basic things that we can do to decrease spread? And we do have a Faith Leader Toolkit that Carla will go into that gives you much, much more granular guidance on this. But just to talk a little bit about some of the science, if you go to the next slide, please. There we go. So the first thing is, again, avoiding large gatherings and crowds. Again, anytime you have people together, there's a chance of spread. That's just the basics of the spread. And then we talk a lot about the 3 Ws, and it sounds so simple and so basic. And I know people might say, really, you're going to tackle a pandemic, a global pandemic with these simple 3 Ws, but the science behind these 3 Ws, we're learning more and more, gets even more compelling and even more, in my mind, optimistic and powerful. And then we'll go into that just a little bit. But again, the 3 Ws, hopefully you all know this by now, it's seared in your brain, but wear a face cloth covering. Again, that is getting at that. 75% of people may have an infection, not know about it. That prevents those respiratory droplets from coming out of somebody's mouth. We also are learning that it also can be protective of another person, preventing the introduction of the virus into that person. Waiting 6 feet apart. Again, we talked about those respiratory droplets in general tend to spread less than 6 feet, so that helps. The airborne, we talked about, can travel farther, and so that ventilation is important, but that respiratory spread is most at risk within that 6 feet. And then washing your hands really, really well, that lessens that spread of touching a contaminated object and then touching your face. On the next slide, I'll just show you a little bit of data, only because I do like data, and a link to the study if you want to drill in as well. There was a study that came out just a couple months, probably maybe months ago now, that really able to quantify for us the protective effects of these 3 Ws. This was a study that looked at people who had the COVID-19 infection and what was the risk of them spreading it to another person, depending on what the other person was doing in terms of preventive strategies. And the risk of an infection, if you were exposed to someone with the disease, decreased by 85% with that social distancing, again, staying that 6 feet apart, 77% by always wearing a mask, 76% by decreasing that duration of contact to less than 15 minutes, and then 67% by frequent hand washing. So that is really, really high. That is powerful prevention in these very simple guidance, which is why we're pressing them so hard. And then finally, we also had questions in the chat about when will a vaccine be available, and I'm really excited about this because the vaccine will be one more, it's another arrow in our quiver of prevention, and I'm really excited about the vaccine. You've all probably heard just in the past week or two, we've had really, really good news about our two front runners, Pfizer and Moderna, about the effectiveness of this vaccine. 95%, that is huge. When the FDA were making the benchmarks for the vaccine, they were going to even allow a vaccine that was only 50% effective. The fact that we are up at 95% effective is huge. This could be a huge game changer. And the really nice thing, at least about these first two, there's many, many vaccines in clinical trials right now, but these first two, the Pfizer and the Moderna, have not had any significant safety concerns in the clinical trials to this stage. So that's really good. So I'm very, very excited about that. On the next slide, I'm just a couple slides on vaccines, and then I'm stopping and turning it over to my colleague. But one of the things that, and we have, and we can certainly come back and do a longer talk specifically on vaccines if this is a topic of interest to you. But one of the things I wanted to highlight, because I do know that there is a concern of how can the vaccines be safe if they've been sped up and things are, and it's being introduced so quickly? Isn't that some way that maybe the safety is being compromised? And that's an exceedingly reasonable concern. And so one of the things that I wanted to highlight is specifically how this COVID vaccine, how it's been developed and manufactured, and how is it different than typical, which has allowed this accelerated rate. And so basically what the federal government has done, instead of doing things in a serial nature, meaning that you do all the safety and efficacy tests first, and then you ramp up production. What the federal government has done is done these processes in parallel. So on the top row of this slide, you'll see this is all the safety and efficacy and clinical trial path. So vaccines go through our three phases of clinical trials. The first phase and two really look at the safety effects. What are the side effects? Do we think this vaccine prompts actually in the body what we expect vaccines to do, that it prompts an immune response? And then phase three then really looks at, does the vaccine actually protect people? If you get the vaccine, will it prevent you from getting the infection? And so all of the typical phase 1, 2, and 3 steps have gone through in this vaccine just the way every other vaccine. One of the beauties of this, though, is that they've recruited so many people, huge amount of recruitment, way more than typical, that they've been able to gather data more quickly because they've had so many people in the clinical trials, which is one reason that's been sped up. The other piece, the bottom here, the manufacturing and large-scale manufacturing row, is that they started producing vaccine at the beginning of the clinical trials. So whichever clinical trials seemed to be effective, they would already have vaccine ready to go, which means they're going to waste vaccine of clinical trials that didn't go well, but of the trials that go well, they have it will supply already. And so that's one of the reasons that we think we'll have vaccine earlier, because they've already started producing, waiting for the good news. We do, though, expect that even though we will have vaccine, we think, as soon as the authorizations go through. In the very beginning, we will have limited supply. We think we may actually have limited supply maybe before the end of the year, but just want to make sure we have expectations that we won't have enough for everybody who wants it, probably closer till the spring of next year. And then finally, on the next slide, I just want to talk a little bit about our guiding principles about our vaccine planning and distribution. And then the very last one, just thinking through, again, that expectation of our prioritization, and then I'll stop. We think all of our response to COVID, we really try to route in guiding principles because we know the specifics, the logistics, some of the science will change, but we think it's exceedingly important to be guided in foundational principles. I mean, you'll see these principles that we've had for the vaccines that parallel our overall COVID response is really ensuring equity and equitable access to vaccines, making sure we're being really inclusive with our state and local government, our private partners, our key stakeholders, and especially those from our historically marginalized populations. We've been very intentional about bringing people into our process. Want to be sure that we're being exceedingly transparent and accurate, making sure we're getting that information out. We do know that people have some hesitancy in this vaccine, so we're trying to be as, again, transparent as possible so people feel like they do have the information that we have to help guide their decision making. We are building a data dashboard for our vaccines, just like we have with our cases, so people can track along with us and see what we're seeing, and then making sure we're doing this continuous evaluation, continuous improvement, so that we're ensuring that we're using all of our resources in the best way to serve our people. And then finally, on our last slide, if you really want to drill in, you can look at the 115-page vaccination plan that we submitted to the federal government on the 16th. We will be making iterations of that as we learn more, but please feel free to look at that. It's posted on our website. And then the very last thing, again, just this setting of expectations, as I mentioned, we are excited that we may get vaccines soon, but not enough for everybody in the beginning. And so we worked with our external partners, including the North Carolina Institute of Medicine, who convened for us an external advisory committee that helped us think through our prioritization. We based it in the National Academy of Medicine, the framework for equitable allocation of vaccine. And we have used what we call a risk-based prioritization. So thinking through people who are at the highest risk of exposure and people who are at the highest risk of complications. Just like I was talking about earlier, who are those people at highest risk of complications if they were to get the infection. And so you'll see that right in the beginning, who is prioritized would be our healthcare workers at the highest risk for exposure, those staff and people in skilled nursing facilities, nursing homes, those congregate settings where we know there's very high risk of outbreak and people of very high risk for poor complications, and then adults with 2 or more of those chronic conditions that I highlighted that put them at high risk. And then we are prioritizing those people, again, who are at high risk of exposure based on those settings, so be it nursing homes or frontline workers, or people who are in homeless shelters or incarcerated populations where not only are there high risk of complications, but high risk of exposure. And so that's our phase 1. And then as you look at our plan, you'll see how we have, in a stepwise fashion, plan to then offer it to people who then are at lower risk for themselves of complication and lower risk of exposure. So with that was a fair amount at you, but we wanted to be proactive in answering a lot of the questions that we got. So I'm going to stop there and turn it over to Carla.
Thank you, Dr. Tilson. Betsy, that was so informative, and I do think that you answered a lot of the questions. As you know, we solicited questions through the registration form, hoping to help us inform how we were going to talk. And there were a lot of questions about how to safely have services, how to, whether indoors or outdoors, how to safely clean your facilities, and a lot of other questions that I'm really excited to be able to share with you some resources that have been developed specifically for faith leaders that will answer many of your questions. So if you wouldn't mind going to the next slide. You know, next week is Thanksgiving, and I know people are planning on what they're going to be doing to safely have Thanksgiving plans with their families, and of course the ever important Black Friday shopping. And so North Carolina has developed guidance for both Thanksgiving and Black Friday shopping. You know, gathering virtually is the best scenario to keeping things safe and but if you are going to gather together, you know, we recommend that you keep gatherings small. No gathering should be larger than 10 people indoors or 50 people outdoors. Gather outside if you can, or open windows to increase ventilation. You can arrange the space or seating so everyone can maintain social distancing during the gathering. Practice your 3 W's, wearing a face mask, waiting 6 feet apart, or washing your hands. Encourage your guests to avoid contact with people outside of their households for 14 days before the event. Avoid close contact through handshaking or hugs. Limit the number of people handling or serving food. You can encourage your guests to bring their own food using disposable utensils and dishes. And then, of course, cleaning and disinfecting commonly touched surfaces, such as door handles, sink handles, and bathroom surfaces. Secretary Cohen said, she recommends if you're going to be in person, keep it small, keep it outdoors, wear a mask. If you're going to be traveling or gathering with others for the holidays, it's highly recommended that you get a screening test prior to traveling outside in meeting with people outside of your immediate household. So on our website, there are additional guidelines that you can use. And following this webinar, we will be sending out some materials, including a copy of this PowerPoint, along with a one-page sheet that will answer a lot of your questions, and you'll be able to get those resources. If we could go to the next slide. One of the other guidance documents that have been created is guidelines for private social gatherings, and it has also been posted on our website. These include guidelines if you are going to be hosting or attending a private gathering, like a cookout or a holiday meal. If we could go to the next slide. If you haven't already downloaded our Slow COVID NC app, I highly recommend that you do this. It's available on both Apple phones and Android phones. It's a free smartphone app, and it'll notify you if you have been in contact with somebody who has tested positive for COVID-19 for greater than 15 consecutive minutes. So if you're in a grocery store and there's been somebody who has tested positive for COVID-19 and you've been in their vicinity for more than 15 minutes, you'll get a notification that you have been potentially exposed. It only works if everybody downloads it. So the more people who have it downloaded, the more likely you are to get that notification if you have been exposed. You can download it for free, as I mentioned, and there's some more communication toolkits on our website that you can use to help spread the word about this app. The next thing that I want to point out is resources that were developed specifically for faith leaders. On our website, there's a faith leader toolkit. It's available in both English and Spanish, and it includes 10 actions faith leaders can take to respond to COVID-19. There's some really popular items within those 10 actions. It includes sample talking points that you could use in sermons, or I was talking to one faith leader and they said they were going to be using it on their marquee out in front of their building. There's sample language for your website and newsletters, maybe a Facebook posting or a Twitter message to your congregation. There's even sample emails that you can use to encourage your members to get tested for COVID-19. Also on our website is an interim guidance for places of worship. It's available in both English and Spanish, and it includes strategies that places of worship can take to social distance and minimize exposure, promote cleaning and hygiene in your houses of worship, monitor for symptoms prior to entering the house of worship, and protecting your vulnerable populations. It includes a lot of the information that many people asked in the registration form. So we hope that you find that very helpful. We could go to the next slide. Many congregations have attached to their congregation childcare facilities or even a school. And so we are also including in here guidance that has been developed for childcare facilities and for K through 12 schools that includes information to make sure that you have everything that you need to safely protect the people who you are working with and the children that you are working with. And then our next resources that I wanted to talk about, there's a few of them on this next slide. The first one is the COVID-19 Support Services Program. This program provides support for people who need to isolate or quarantine after testing positive for COVID-19. People who are eligible can receive assistance with their rent or mortgage payments, assistance with groceries and medicine, transportation and medical appointments, and even personal protective equipment. It is not available statewide at this time. It's available in a limited number of counties, but there is information on our website about support services. And so you can look to see if your county is currently using that service, or has it available, rather, is a better way to say that. I noticed in the chat just briefly where people were asking about how do you know what testing events might be coming up. So in the materials we're sending you is a link to a no-cost community testing event site. You can type in your county and it will give you a list of all of the community testing events that are coming up that are free of charge, and anybody can go and get tested at those events. There's also going to be a link where you can look up other testing sites that may have a cost associated with them, but it will let you know where all of those testing sites are. So that will also be included in the materials that we send you. And I don't know if you're aware, but faith organizations do have the ability to request masks or PPE supplies, cleaning supplies from the state of North Carolina. And so included in the materials you'll be receiving are a link that there is a link that you can use to request supplies. You will want to put in that you're a faith organization when you make that request so that they will know that what you are using those supplies for. And, you know, we have recently been making calls to faith leaders all across the state for the last few weeks. And one of the things that we've been hearing the most frequently is the concern of the toil that this pandemic is having on many of the members of your congregations. It's a stressful time for everyone, and many congregations are holding services in new ways. Maybe they're having only virtual services, or they're limiting contact in their service members. A lot of people are not able to worship the way that they would like to worship, and it's having a mental toll. Many of the pastors that we've talked to have reported they've seen an increase in depression, an increase in divorce rates, and even an increase in suicides. It's a trying time for everyone. There have been 2 helplines that have been established to help North Carolinians who are coping with COVID-19. The first is Hope for NCP. Not NCP, sorry, Hope for NC. It's available 24 hours a day, 7 days a week to all North Carolinians. It's a free service where callers can speak to mental health professionals to get mental health and resilience supports that help them cope and build resilience during times of crisis. The second helpline is available for frontline workers and their families, including healthcare professionals, emergency medical specialists, first responders, and other staff who work in healthcare settings. It's called Hope for Healers. The numbers you see on the screen are the numbers for those 2 helplines. In the links that we send you, will include more information, including flyers that you can print out and put up congregation, or maybe share with your congregation for those services. We hope that they will be helpful to well, to everyone, actually. So as I wrap up this, I just want to share with you that all the guidance and the documents that we're sending to you are meant to be of support to you. Our goal is to provide the best possible support that we can to the faith leaders in North Carolina. And we join with you in hoping that all North Carolinians stay safe. And we really would like to hear from you if there are additional supports that you need or information that you need. And I know that you're putting some in the chat line, but in the email that you sent, it will also include my contact information. And I want you to feel free to call me if you need any assistance, and I will do my very best to provide that to you as quickly as I can. So if we could go to the next slide, there's a campaign that North Carolina is doing called Whatever Your Reason, Get Behind the Mask. Everyone has a reason as to for why they want to do their very best for the family. Maybe it's their families, maybe it's their congregation, maybe it's the people they're serving by providing meals. Everyone has a reason to get behind the mask. And so I hope that this will help you have the tools to be able to do this. I have a few things I want to finish up, but before I do that, we have invited a few faith leaders in our community to share with you what they have been doing in their community. And so first up, we have Reverend Tyrone Watson and Dr. Robin Peace, who they're both with the Unified Robeson County NAACP. Reverend Watson and Dr. Peace, I'll turn it over to you. You might have to unmute though.
Can you hear me?
Yes.
Okay, so I didn't realize that me jumping on this call, I was going to have to say something. I don't know if Reverend Watson is on the call or not, but certainly I found the presentations by both of you to be very helpful. And I look forward to sharing those comments with some of the pastors and spiritual leaders in the southeastern part of the state. I'm in Lumberton, North Carolina. I'm a family physician. I've been practicing in Robeson County for 22 years. I'm the president of the medical staff for Southeastern Regional Medical Center, our local hospital. And so I have a platform in order to run my mouth as it relates to trying to protect the community and people from COVID-19. I just recently did a short video that is on our website because I felt the need to really reach out again with Thanksgiving and Christmas coming. I appreciate the slides that talk about that. And it made me feel pretty good about what I said, because those are some of the things that I said on my video in terms of getting a COVID test 4 or 5 days before, because I heard Dr. Cohen say that on the news brief. And so I have been doing radio broadcasts in Robeson County. Actually, Reverend Watson, we connected yesterday, and I'm going to be on the radio station, the local radio station here next Tuesday to do another one. I wrote an editorial for our local paper. I really think that even though we all are tired in the medical community, as the medical leaders in our local areas, we have to be a part of getting the message out because the patients, they know us. You know, certainly I have the utmost respect for, you know, doctors at the state and federal level, but I'm a country doctor. I practice in the country, and, you know, the patients that I have connected to and touched and impacted over the last 22 years, they trust me, just like people trust their pastor, which is why I have been specifically trying to help to educate the pastors. I was just on a call last Friday with a group of pastors in our area. They asked me to come, which I thought was great. I made the time to give them my thoughts about staying safe. So thank you for this platform. I think it's great.
If I could just chime in, that is awesome. Make sure that you have like my direct contact, email, cell phone, whatever you need, so that we can just kind of be in mind meld, whatever you need. That's just awesome. So just call me anytime, day or night. Let's just stay really well connected, because that's great.
Yeah.
Thanks.
Absolutely. Yeah. And I was just thinking, we have in our area a community provider call that has doctors in our network, as well as private practice physicians to come together and talk about the state of COVID in our area. Our medical director for Southeastern's ER, he said just this week that the pandemic is the worst that he's seen since the beginning in Robeson County. As I'm sure many of you know, the rural counties in the state of North Carolina have more COVID than suburban and larger counties. And so when he said that, and then he said, because I specifically was talking with him about church and whether or not he thought it was safe. And he told us on that call that of all the patients that he's seeing, the older patients that are really sick, even the ones that are sick but not sick enough to be in the hospital, half of those elderly patients contracted COVID from their church setting. And so the pastors have to make their vulnerable members feel comfortable about staying at home, letting them know that it's okay that they stay at home during this season, that give them another way that they can feel connected to their congregation, that they can pay their tithes and offerings, because the pastors on this call know that some of their most dedicated members are the elderly ones that are the most vulnerable to succumbing from this virus. And so they have to be the ones to say, it's okay, sister so-and-so, that you stay home during this season, and we will, and have an alternative to the worship, whether it's, YouTube or Facebook Live or a phone or a Zoom call. We have our Sunday school lesson via Zoom. And so that's one way that we're staying connected with some. But there are a lot of people that they're challenged with internet and so on and so forth. So, those are the places that I think that help to be made. But yeah, the pastors have to let their vulnerable congregation know that it's okay. And I have not been to church since February, and I miss it. I love church. I love to worship, but I want to worship, and I want church to be the way that I want, and I want to feel comfortable I want to feel comfortable and it's safe. And I don't think it's safe. Personally, as someone that loves church, I don't think it's safe, particularly when you're living in an area that's really high with COVID, as we are in Robeson County and the surrounding areas. When I look at the larger cities, it may be different there. But I think that a part of what every pastor needs to consider is how much COVID is in your area. And that needs to be taken into consideration as to whether or not you are meeting in the sanctuary, even if you're able to follow the 3 W's, that you need to consider. And the amount of time that you're there. Because my church, we would worship for 2 hours, okay? And so people have a hard time keeping a mask on in my exam room for 15, 20 minutes. Even if the pastor is saying wear your mask, there are gonna be times that people are gonna be messing with the mask. And that also needs to be considered. Thank you, I'm done. I didn't even realize I was going to talk all that much, but anyway.
Well, I really appreciate you. And just looking at the chat, I think everybody appreciates your words as well. I have a feeling people are going to be asking us for your contact information, so be prepared.
I'm prepared. You know, I'm prepared. I give myself away.
We also have with us Pastor Christopher Edmondson with White Memorial Presbyterian Church, who was going to share some of the things that his congregation has been doing. So Pastor Edmondson, are you with us?
I am. Thank you. Although I'm not happy that I have to follow Dr. P. So can you slip somebody else in there real quickly? Thank you so much.
I'll be your buffer.
Dr. Peace, that was wonderful. Love your area of the state, and came to Raleigh to White Memorial from Edgecombe County, which is another one of our more rural counties that has certainly suffered unduly with this pandemic. We did what a lot of churches did. We started off in March, and really from March through October, worship virtually only. And we're in an area with good internet coverage, and we could do that pretty well, limiting the number of worship participants, really limiting singing more than anything else. All the questions for the singing that have been asked, we have come up with a solution, and working with some doctors in our congregation and being aware of what Dr. Peace just said about the rate of the spread in our five most common zip codes that our church pulls from. We feel good about what we're doing now. But when we went back to virtual in person, we capped attendance at about 25 or 30%. We roped off pews so that there were spaces between people, and we were able to sort of adapt some software for social distancing with seating. I think smaller congregations, again, I was in a smaller church in Edgecombe County before I came here, could certainly do it, just with people coming in and using pieces of paper that say, don't sit here, sit here. There are ways to do that. We do require masks. Someone said in the chat, what happens if someone's mask falls down or if they take it off? We have some, what I would call very brave ushers. We've developed this little sort of business card where they just hand a card that's a friendly reminder to place your mask on appropriately. I've had to a couple of times point to my mask from the pulpit and seen people embarrassingly pull it up over their nose when I do so, and those sorts of things. We have found that our folks have been wonderfully willing to wear masks throughout the duration of the service. I don't pretend that would be the experience for every single congregant, church member, person showing up for temple, wherever it may be, Friday prayers. But our folks have been wonderful to wear the mask. We did what I want to call a site survey. So our tight spaces, we put stickers all over the floor, practice social distancing. Our sanctuary will seat close to 600. And so it's lots of space in there, lots of air above and so forth. But in the hallways leading to it, it's a little tighter. So that's the places we have put the reminders about the 3 Ws and put stickers on the floor. The question about singing, we removed the hymnals from the sanctuary to push down on contact. And instead, we print the hymns and we place those in the seats that we think people are coming to. And then we have song leaders who sing with a microphone and then with a mask or a singer's mask. And a singer's mask is a special kind of mask that's developed for people to sing, that's been approved by different medical associations. And then we encourage the congregants to simply read along with the hymn and don't sing, or at the most hum. And we have found that that has been very well received by our church members. And for that, I am really, really grateful. One question we got all the time was, would you do worship outside? And we would, except that we're in the middle of a city and we're fairly landlocked. We don't have a big front yard. We don't have virtually no parking around our church. We're in a neighborhood. And so we just really waited it out to where we felt like we could provide as safe an experience indoors as possible. But we always tell our members when they either call us or on all of our materials that we send out, to Dr. Peace's point, that we can't guarantee 100% safety, and our at-risk folks, we want them to be very mindful of that. I will share that what we found since we went back to some in-person worship is that attendance was much lower than we expected. which says to me our people are taking the virus pretty seriously. We had planned for as many as 80 or 100 in our large space, and our largest Sunday so far has been 55 to 60. And so we are finding that our at-risk folks, those older members that Dr. Peace was talking about, are staying at home and trying to figure out how to worship virtually, working with grandchildren or neighbors to try to figure out how they can participate in their worship service. And so far, we haven't been notified by the county health department or by the state that we've had any community spread in our church, but it's been from minding those 3 W's very closely, not singing, humming only, or having people just read along silently, and really looking at our space to find out where the at-risk areas were. And we also increased the time, last thing, between our worship services so that our volunteers could go through with basically bottles of sanitizer and spray those spaces, giving a good 2 hours between the services for the air to clean out through the ventilation system. So that's what we've done. I don't know if it will work with everyone, but we feel confident that we are providing as safe an experience as possible by following those kind of protocols.
Well, thank you so much, Pastor Edmondson. I think those were great tips. And I notice in chat there are a lot of people that are responding positively to you too. So you did great following up on that.
Thank you very much.
We had put into our agenda next that we were going to take questions. And I see in the chat that a lot of questions have come through and we've been able to respond. But based on the time, I think what we're going to have to do is try to follow up on some of the questions we weren't able to get to today through our email. And as a reminder, my contact information is going to be in the email that you receive with all of these resources. So, if you have a question and it didn't get responded and you need to answer quickly, go ahead and email me individually and I will get that response to you. I don't know, Lindsay, if we have the ability to turn back on the PowerPoint and go to slide 39. But we have a call to action for all of you on the call. And the last I looked, there were 133 people on this call. And so I think that this is going to be an awesome call to action. We're asking you to talk to your congregations this week about how to be safe this Thanksgiving and during the upcoming holidays. Remember, keep it small, stay outdoors, wear masks. Consider getting a test. We want you to check your email after this conversation to see a message from us with the resources. And then if you would share those resources with other faith leaders in your community, those who weren't able to join us today, so that they can get the information to their congregations as well. And then pull up that faith leader toolkit. I said there were 10 actions. I bet 3 of them are ones that you might be able to use right away. So we're challenging that you do 3 new actions outlined in the faith leader toolkit. And we are at the end of our presentation, so I will turn it back over to Chris and Jennifer to wrap it up.
Thank you so much. Thank you for all of this, and especially the interaction. You will be getting information very quickly. I want to just hold up 2 things and have them dropped in the chat box and invite you to check out healthandwholeness.org. That's Partners in Health and Wholeness with the North Carolina Council of Churches. We have a toolkit, a mental health toolkit available for worship communities, as well as a harm reduction toolkit. With COVID, we are seeing spikes in overdose deaths, people who use substances, and obviously the toll on mental health that was already mentioned. So those are going to be in the chat box and they will be in the follow-up, and they are available on our website. So thank you all so much. Please reach out if we can be of service to you. And with that, I'm going to send it to our Executive Director, Dr. Reverend Jennifer Copeland.
Thank you, Chris. We started this hour together with lament, but we end in a moment of hope. And so let us give thanks. First, let us give thanks to the giants of the North Carolina Council of Churches on whose shoulders we stand and have stood for 85 years. Let us give thanks to the Department of Health and Human Services, whose work is on the front lines and assists all of us as we deal with this pandemic. Let us give thanks to the faith communities who are at the grassroots of our communities, who do the good work of taking care of their congregations and setting the example for all to see. And let us give thanks to God. Let us go forth now from this place to serve God and our neighbors in all that we do. Thank you. Have a great day.
Thank you all so much.
Hi, everyone. Have a good afternoon.
Bye.
Thank you.
Thank you.
Lindsay,
It's
will
been
you be
wonderful.
sharing